Good morning everyone, and a big thank you to the organizers for letting me be here. It's a wonderful conference and I'm really happy to be a part of it. So my job today is made very easy by the speakers who have spoke this morning before me, especially Dr. Praval, Dr. Samvedam and Dr. Kaushik. Now I'll be focusing on some other things which we can do to improve the outcomes of AKI, apart from obviously doing dialysis. So as we know, AKI can have two outcomes. Either the kidney, the AKI with the initial insult, AKI progresses, then we do everything correctly and the kidney recovers, maybe partially or completely, or we do everything correctly but still patient or the kidney doesn't recover. So the objective of the talk today will be that in next 20 minutes we'll be seeing how to mitigate the ongoing kidney insults which will halt the progression from a stage 1 AKI to a stage 3 AKI, and how to reduce the complication of AKI which will be happening all over the body to all the organs. So let's begin with a simple case. It's a very common case in our scenario. Especially I come from a government sector, so we see these kind of cases day in and day on. A young lady comes with 32 weeks gestation, pregnancy-induced hypertension on antihypertensive. She comes with bleeding, seizures, she is tachycardic, hypotensive and pale, and is diagnosed with preeclampsia with abruption. Her labs come back, she is anemic, she has thrombocytopenia, creatinine is little high for that months of gestation, and DIC profile is deranged. Gynecologist start her on Maxulf and take her for emergency LSCS with an 800 ml of blood loss. We come to see her post-op. She is still tachycardic. Now she is on noradrenaline, which is started intraoperatively. She still does not have edema, and her urine output has been only 80 ml since last 4 hours, and the repeat creatinine is now 1.8. So what I'm trying to convey with this case is that in every patient of AKI, there are lots of ongoing insults which are there, which can be looked into, and if prevented on time, can help us in saving the further insults to the kidney. So what can be the insults in this patient? So it is no brainer that she definitely has volume disturbance and she has hypotension. Previous speakers have dwelled onto it. I would just like to put more emphasis on the part that early volume resuscitation, though very important, but it should be done very carefully with very careful assessment to not to take the patient from underfill to overfill. And there is no proven benefit of colloids over crystalloids, except in this case, like if the patient is actually in hemorrhagic shock, or in cases of where supposedly there is liver disease or HRS where albumin has been shown to have some benefit, and there is some evidence to suggest that balanced salt solutions might be better because of their low chloride load, especially when the volume we are infusing is high. But we definitely know now with lots of evidence that higher volume overload will lead to poor outcomes both for the kidney and for the patients. There are multiple studies, and the largest one is this, which showed that 10% weight gain in ICU led to a higher mortality with an OR of 2.07 with a pretty narrow confidence interval. So we definitely don't want to fill them up with fluids. Talking about hypotension, it was very well covered by Dr. Samvedam. I am just trying to tell that the target map suggested is 65. We still don't know what is the appropriate target, but we should always remember this concept of relative hypotension. What I want to tell here is that patients who are chronically hypertensive do worse when there is an acute decline in blood pressure, and their kidney is not able to sustain that acute decline, and the kidney insult gets more potentiated. It is true for people who are chronically hypertension, and also true for hypertension in the state of pregnancy. This has been shown with many studies, and also there have been studies where subsets of patients who are hypertensive, like in this study, the intensive control and a normal control of MAP did not make a difference for everyone with shock, but in a subset of chronic hypertensives, a lower MAP will lead to a higher rate of AKI and RRT, AKI and need of RRT. So people who are chronically hypertensive, they do not tolerate acute hypotension that well. That is something which we need to understand and individualize in our patients. What can be other ongoing insults? We should always do a very, very keen, thorough chart review. Apart from other things, Asha was getting these drugs, Genta, Maxelf, Levetiracetam, and obviously she was getting hydrated. So there are drugs in pregnancy, in AKI which needs to be stopped because they can in their own right cause acute kidney injury. We all know this list, this is an elite audience. KDICO has specifically given guidelines for the use of aminoglycosides where they have recommended single daily use and use of more thorough therapeutic drug monitoring when it is being used for more than 24 to 48 hours. These are drugs which we really need sometimes and we cannot go without them. So we should be using them very judiciously and we should try to curtail the duration of the use. And obviously the other drugs like NSAIDs, ACE-ARB should be withheld. I am not sure if we are in the position to tell whether SGLT2 should also fall in this category now, but that is a rational thing to do pending future evidence. There was lots of buzz about the toxicity of piperacillin tazobactam and vancomycin when combined together. Apart from the toxicity of vancomycin in its own right, it can cause crystal related toxicity. But there was this nice, there were, before this study, there were lots of smaller studies which had come and shown that people who were getting piptaz and vanco were showing an increasing trend of creatinine, which was also shown in this study. But these authors went one step ahead and they showed us that this increase in creatinine was not actually associated with a change in cystatin C and there was no increased need for renal replacement therapy, showing that whether, putting forward the hypothesis rather, that whether this toxicity is a pseudo toxicity where only creatinine is rising and it is not really causing some problem to the kidney. That needs to be further studied, replicated in larger populations. There are drugs, apart from being nephrotoxic, then there are drugs which are renally cleared, which need dose adjustment, mostly dose reduction in patients in AKI. Sometimes we might need to increase the dose, but that's when they are either on CRRT or on hemodialysis. These are drugs which can affect other organs, like they can have CNS side effects. For example, levetiracetam, it can, patients can get into very high toxic levels and have neurological complications in those who have severely depressed kidney function. Baclofen is also a very common example which falls in this category. So coming back to Asha, we would try to avoid gentamicin upfront. I would still give it if it is the only drug which comes sensitive or my antibiogram of the department shows that way, but I would like to avoid it upfront in a patient who is oligoanuric with a rising creatinine. Maxelf is the drug of choice for eclampsia. It is still the best proven therapy for preventing further seizures. So I would like to give it very closely with monitoring of levels as magnesium is renally cleared. Same for levetiracetam. And if my fluid hydration volume is going up, I would like to give balanced salt solutions. So we do these things. Now it's post-op day 1. She is in positive balance. She is out of inotropes, but her blood pressure still remains 100. Remember, this was a lady who was hypertensive, requiring 2 drugs for control of blood pressure pre-delivery. She has some evidence of edema now. So now what do we do? Whether we give her more fluids because fluids were causing a little bit improvement in her urine output, whether we give her inotropes because blood pressure is still little lowish, whether we do both, or whether furosemide can help us in managing fluid overload but won't change the outcome. So talking about diuretics and their role in acute kidney injury, there was a theoretical rationale given that because they cause, they shut down the sodium potassium chloride transporters, they will lead to a decreased oxygen load in the medulla and hence already where the oxygen is less and the tissues are getting ischemic, it might help to give diuretic. However, this rationale was not supported by evidence, and as of today, KDICO suggests against the use of, actually recommends against the use of diuretics to treat AKI, to prevent AKI, and in any sort, except when the patient is in volume overload, when it is required for its own right. It does have some early prognostic value. We do furosemide stress test, furosemide challenge test. When we give furosemide and if the patient pours urine, we might think that the patient will have a better response and the tubules have not completely become necrosed and the diuretic is still acting on them. Now going to acid-base abnormalities quickly, metabolic acidosis is the one which we all dread and the most common of the lot. There are lots of systemic effects of metabolic acidosis. I have specifically made cardiac and circulatory effects bigger here because they are the most dreaded one, causing various arrhythmias, causing direct myocardial depression, sometimes myocardial infarction. However, there are other effects also like respiratory and cerebral effects. Treatment of myocardial metabolic acidosis again is a little bit controversial when it comes to real cutoff, not much data to support, but usually what is recommended is that when the pH goes less than 7.1 and the rate of change of acidosis, the worsening of acidosis is high, then we should be treating metabolic acidosis in the setting of acute kidney injury, and obviously always we should be focusing on underlying cause and to try to correct it. How we treat metabolic acidosis in presence of acute kidney injury, we can give it either bolus or a continuous infusion. A continuous isotonic bicarb infusion is more physiological, much better tolerated, and we should be trying to avoid bolus as far as possible. As I have listed here, it comes with a load of various complications. So best patient for this IV bicarb therapy in AKI, in my opinion, would be someone who is not hypervolemic, has pH less than 7.1 and can tolerate this isotonic bicarb solution for at least 5 to 6 hours and does not warrant dialysis for its own right for other pressing indications. Apart from that, patients who are hypervolemic, we would rather think of dialysis rather than giving bolus concentrated bicarb. Few patients can also be alkalotic with acute kidney injury. Most of them are hypovolemic, like for the causes I have listed here. Some people also are alkalotic because they have underlying lung disease, like a post-hypercapnic one. The best way to understand what is causing the alkalosis is to get a urinary chloride. It's a very cheap, readily available test. It actually tells you about the volume balance and whether they'll be responding to your fluid therapy or not. The fluid of choice here will be normal saline only because it has a higher chloride load and it will treat metabolic alkalosis beautifully. Coming to electrolyte imbalances quickly, hyperkalemia is the dreaded one, mainly for its cardiac complications. This is a nice algorithm from UpToDate, and you can just focus, because it's a busy thing, you can just focus here this middle thing where you think about what is the level of potassium. If it is more than 6.5, it is definitely an emergency. If it is more than 5.5, there is significant severe loss of GFR and ongoing tissue breakdown or ongoing potassium absorption like a significant GI bleed, these patients will deteriorate very quickly, and that takes to a hyperkalemic emergency, which are best managed by dialysis. And interim we can do some medical management in terms of stabilization of cardiac membranes. The dose required is 1 gram, which is 10 ml of 10% calcium gluconate. It should be given by continuous ECG monitoring. When our patient is little stable, we can try other medical management like transcellular potassium shift by insulin, beta-2 agonist. Bicarb therapy is listed here, not very, it is actually controversial. I would like to just say that when we are doing this, when we are shifting potassium from outside the cell to inside the cell, we should always remember that this potassium will not be available for dialysis if you take the patient after dialysis after 1 or 2 hours. And these are the patients who will develop rebound hyperkalemia post dialysis. Once you have stopped dialysis, you have confirmed your potassium has dropped down to less than 4, they might require again a session of dialysis after a few hours because the potassium was all inside the cells because of our therapy. Removal of potassium from body is possible when there is a good amount of renal function with loop diuretics. Cation exchange reasons, we do not have sodium polystyrene sulfonate, we have calcium, which is the commonly used K-bind. It is not very effective but can be used if you are pushed to the corner. We have newer molecules coming up, patiromer and sodium zirconium cyclosilicate. I have not personally used patiromer, but I found that this is available in India at this rate. I would like to listen from the house if someone of them have used, but my colleagues who have used in US and Canada, they vouch for its efficacy, and it seems a reasonable thing when the patient is in a chronic state. Coming to hyperphosphatemia and hyperuricemia, here I would like to say that this is little controversial. There are people who do treat it, but I would say that evidence till date suggests that there is no need for medical management. They are just a marker of severely reduced GFR, and both will be removed by dialysis if the patient needs for other indication. Apart from, this is out of the setting of malignancy and tumor lysis syndrome, where we treat hyperuricemia with rasburicase at 0.2 mg per kg per day. Hypocalcemia is again a common problem in our patients. We should always be looking at either ionized calcium or corrected calcium, and if it is severe, it needs prompt early treatment. Hypermagnesemia can occur when the patient is getting iatrogenic magnesium, like my patient was getting that, and symptomatic hypermagnesemia with CNS depression warrants dialysis. When we are giving magnesium for hypomagnesemia in a patient of AKI, which is also not very uncommon because these patients are malnourished, they are in ICU for a long time, we should remember that magnesium is renally cleared, and while supplementing magnesium, we should remember that we should be doing frequent monitoring and giving small doses if possible. Coming to a very important problem of malnutrition in AKI, these are the factors which can cause malnutrition in critically ill patients with acute kidney injury. This is the recommendation given by KDIGO when they say that the glucose should be targeted to 110 and 149, and you can see the strength of evidence is 2C because there are no large trials which actually support this range of 110 to 149. There was this, they based this, the recommendation on this single RCT which said that the surgical patients did better in terms of AKI and RRT when they were in a intensive glucose control arm. But then it was followed by this larger RCT, which is the largest in this topic with 6,000 patients. They found that there were no difference in RRT rates, but higher mortality in the intensive group. And it is very important to remember that patients with AKI, because insulin is renally cleared, they will have more tendency to develop hypoglycemia. And we should be very, very careful when keeping them in a very tight glycemic control. Nutritional support, it is important that they get adequate energy intake because they are, most of them are hypercatabolic. AKI itself is a catabolic state. 20 to 30 kilocalorie per kg per day is recommended. Protein restriction is not recommended, especially in our setting when most of our patients are already protein deficient. These are the values of how much you should give. You can give up to 1 gram in a non-catabolic state and up to 1.5 to 1.7 grams when they are catabolic or on CRRT. Also, when giving nutrition, we should remember that the enteral route is most preferred because it has least amount of complications. Very less data of actual parenteral nutrition in AKI. This Cochrane review, which was published in 2012, 10 years back, there has been no fresh version of this, found that there was insufficient evidence to support the effectiveness of nutritional therapy for AKI, that was a parenteral nutrition. However, the studies which they study in this systematic review were of poor quality. Lastly, coming to uremic bleeding, we know that our patients can bleed. Sometimes they do have platelet dysfunction, but sometimes they are also on anticoagulation for various reasons, maybe because they are also undergoing RRT. So correction of anemia is a very important factor in preventing uremic bleeding. Dialysis itself can improve the platelet dysfunction. Other therapies like DDAVP, estrogen and cryoprecipitate have been studied, but the evidence is scarce and they should be used only when other things fail. This is the last complication I would like to touch upon. This is secondary infection. There is a huge hot topic of discussion, which is organ crosstalk in dialysis, which means that once the kidneys start failing, they give rise to inflammation, which affects everything, including the lungs, including the gut microbiota, and this predisposes, including the immune system, and this predisposes our patients to secondary infections in AKI. There is no doubt that these patients are at a risk of developing secondary infections. We are studying on what are the predisposing factors, and we are trying to identify those. The common thing which we see in our setting is obviously dialysis catheters, multiple manipulations, volume overload, and like I said, the organ crosstalk which changes in microbiome, which lead to impaired host immunity. I don't have any recommendations for this, but I would just say that follow a good antibiotic stewardship when you are treating secondary infections, and also follow your local antibiogram. This is actually, this is a nice table from Oxford textbook, which actually summarizes my talk. It tells us what are the key monitoring parameters which should be done in patients with acute kidney injury, and what should be the frequency of these parameters. So I would like to end by saying this, that this is a very august gathering, where we are, we'll be learning over 2 days, like yesterday and today, about more and more recent advances in how to treat AKI. We have company of CRRT machine on the dais, which is actually a model to tell us how much we are progressing when it comes to newer technologies in managing AKI. But we should not forget these small steps which can make a very big difference. And as it was told by this 0 by 25, which means that 0 preventable deaths by 2025 initiative of International Society of Nephrology, they did a global snapshot, and they found that the mortality was 11% of AKI globally, and it was as high as 20 to 40% in lower middle income countries. And 30% of these patients only completely recovered, and 70% either died or did not recover. So we have a long way to go, but these small steps can really make a difference in our patients with acute kidney injury. Thank you so much for your patient listening.